that better?
That's wonderful.
I like it.
You like it?
Yeah, I love
You
it.
can sleep. Yeah. Let's hope not. All right, we went over a lot of the rights of people last week, and just to summarize, we said that the most important role of the nurse today has become patient advocate. Both state and federal law, when you look into the criteria that surveys use, we said that there are situations where healthcare facilities are approved by the state and the federal government, but the federal government accepts the Joint Commission accreditation instead of them coming in and looking at each. This is just by way of review. We talked about this before. But in both instances, there are criteria there which demand that we personalize care to what the patient wants, and there are other laws of confidentiality which demand that provider professionals share all information with the consumer. Since '86, with the final directives, we had said last week that we've come into really a new era in healthcare and a lot of other things in the States, where consumer is king. Now, I'm just coining that as a phrase. In other words, what the patient or the consumer wants is what you are obliged to do for them. And they have the right to walk away from the services if you're not providing what they want. In hospitals, particularly, well, and in nursing homes, it's become common to do surveys of patients after their discharge. The press gaming instrument is what is used by almost every hospital and nursing home I know of. Press, P-R-E-S-S. Who knows that term, press gaming? Please, if you know something, raise your hand. Do you know that term at all? All right. PRESS-GAMEY, press gaming. It was an instrument developed by a professor at Notre Dame. Years ago, he's probably a gazillionaire by this time. He taught one of my sons, and Bill didn't think he was too brilliant, but he came up with this instrument to survey people after a hospital stay. And hospitals in every corner of the U.S. are committed to looking at those scores and making things better. Because really, they're in competition for the business, and they want to make sure that their clients and their families are happy with the service. This all feeds into advocacy. The prime responsibility of the nurse is to inform the patient, and we talked about informed consent last week. We said that it's not the nurse's job to get a signed informed consent, but it is the nurse's job to put the patient in a state that they are informed and can sign the consent. It is the responsibility of whoever is the admitting person or the primary caretaker to do this. In most cases, in this state, it's the doctor, although in some places, advanced practice nurses do admit and are the primary caregiver for patients. but advocacy has become critical. Ever since '86 and the final directives, which gave pay, and then with managed care and the desire to have people comfortable and satisfied with their hospital experience, it's become more and more critical. We talked about the Patient's Bill of Rights, and it is still in committee in Washington and has gone nowhere. And it's not because we don't care about the patient's rights, but there should be no need to say some of the things that are in there, like the patient is responsible to pay the bills. Well, what do you think? The patient can expect that all information will be given to them. The Patient's Bill of Rights is so basic, it should not have to be legislation. And you should look over that Patient's Bill of Rights. It's in your book. Informed consent has certain elements, and you should read them. The patient should know about alternate interventions, the risks. You should be careful that the patient did more than hear what you said, but actually understands what you're saying. And these elements were discussed last week. You can refuse treatment, and we did some discussion of the mature minor concept and how this is used by the courts and by judges to speak privately to a child to determine. I'm not talking about a 2 or 3-year-old, although even a 2 or 3-year-old can offer some evidence to make decisions on. But often, particularly children who are in chemotherapy for cancer, it is quite common, and where parents want a child to continue forever and go on with more complex courses of chemotherapy. And a child wants to stop. It's not at all exceptional for a judge to call a child in and ask them what they want. A very tough call, because parents frequently want to try everything, and you don't know what's going on inside that child. And the courts have listened. We talked about guardians ad litem, and these are guardians which are designated by the courts when the patient can't make decisions, either because of a medical condition or a mental condition. But there's no ability for that person to make decisions, and often a family member is designated, but a guardian ad litem is a guardian designated by the court. Frequently, lawyers will take on this, and they're very good at it because they know the legal parameters. And all the lawyers I know that have been designated guardian ad litem take the time to go in and visit the patient to make sure they have some sense of what they want, because sometimes, even though a patient is mentally compromised, they can express what to them is quality of life. And we said a few things about clinical death. It's frequently the cessation of circulation and respiratory function, but that is a dated definition. Death is more often determined by neurological criteria today, and that means brain stem death. You can have frontal lobes die and still have a patient live. And that's what happened to Karen Quinlan years ago. Remember, she was the first right-to-die case that went to the Supreme Court from New Jersey. Well, not from New Jersey, anyway. She was the first case that went to the Supreme Court. And she was dead. She was in a persistent vegetative state. But even when the Supreme Court gave the right to remove her respirator, she continued to breathe for 10 years. So, and at that point in time, there were still court cases that didn't get to the Supreme Court, like the Nancy Job case, and they're in your book. But no, so much of this case law was established in New Jersey. Nancy Job was a woman with MS in a nursing home in Lincoln Park, and she was in complete control of her senses, and she wanted to stop eating. That's all she wanted. She wanted to die. And by the time that case went through the Supreme Court, which gave the right for people gave the right to withdraw nutrition, and well, really, it gave the freedom for people in that state to decide they did not want to live and did not want to eat. She was too against her will. And that gave, and that was another New Jersey case that established a declaratory decision. Those are decisions from the courts that established law. All right, the Nancy Job case. But it wasn't in time for Nancy. But the neurological criteria is more commonly accepted. However, it's different in every state. Now, if you, when you're finished here, if you go to another state to work, we said that you have to check with the state boards for their requirements. You have to practice under the requirements of the state you're employed in. You have to apply, or if it's, now I'm trying to think. Yes, we discussed the multi-state compact, right? Yes. All right. If it's a multi-state compact, you're still responsible to practice by the law of the state you're working in. All right, so you have to, and you also should go into the literature to find out what the criteria for death is in a state. Because depending on what state you're in, a nurse may have the right to pronounce death. In New Jersey, you can pronounce death in nursing homes, not in hospitals. But, you know, this is a weighty responsibility. If it's only neurological criteria that indicate death, you better know what you're doing, right? So you would go into, well, I always recommend Google just because it has so much, but Google will take you to the state law for New Jersey. And the NCSBN will take you to the law and the regulations under the Board of Nursing. For instance, let me give you one example. If you go to work in New York, every 2 years you need 30 credits from continuing education. Just like in New Jersey, you have to have credits from continuing education. And I told you, they don't ask every nurse to produce proof. They sample about 25% of nurses in the state. In all of my years licensed in New Jersey, I've only been surveyed personally once. All right? So you may never be surveyed, but you better have the documentation that you've taken the credits, because if they come and you haven't, they will pull your license, right? But in New York, it's more than that. You need the credits, and you have to take courses in addition on spousal and child abuse, on substance abuse, and there is one more. I can't remember. You can go look it up if you want. But you have to take specific courses on these topics. Now, if you're working for someone, like a big institution, a hospital, a nursing home, healthcare, a public health agency, or home care agency, they will frequently arrange for these things to be given for you. But if you're not working for a big institution that can afford to do this, you better make sure you have proof that you took it yourself. All right? New York is very particular about those 3 topics, and there is one more. I'll leave there 4 topics. So clinical death can vary. Just know that. The right to die, and we said this last week, is based on the right to freedom and privacy and self-determination. These are the basis for the interpretation of the Supreme Court in various cases about right to die that have gone the whole way up to the Supreme Court. Another famous case is Nancy Cruzan. I think that was in Missouri, and that gave the right to people who had the designated power of attorney to act on behalf of the dying person. It said that if you've been designated or if you have a close relationship, Nancy Cruzan, again, was a young woman involved in some type of an accident that was on life support for a long time, and her parents wanted the right to turn off the machine. She had no cerebral function. She was being kept alive by this machine, but the law would not permit them to do this. And they went through the state courts and the Supreme Courts. And now, with certain proof, there is the right for not that with those people with the durable power, but close relatives to make that decision. If you can prove you were close and that you really knew what the person would want. It's still a ticklish situation, but it has gone a long way. So much of this has been decided in the courts. And you know that the advance directives were the durable power and the living will established in about 86, around there, which makes it specific that anyone entering a healthcare setting and being funded by the federal government, hear that, he who pays the piper calls the tune. The federal government made law for people who they were paying for. But there's a pattern which is recurrent in the United States, that what happens at the federal government trickles down to the state. So as soon as the federal government established final directives, many states began to accept the same requirements for their private plans, which are executed through the state's Department of Insurance, and for their Medicaid plan, which is paid for half by the state, half by the federal government. But whenever there's any state money involved, states' rights prevails. That's important to understand in this country. Oh, it's 91, sorry. I wasn't going to ask you that anyway, but the patient self-determination was 91. There were other things in 82. Okay, now, do you have any questions about, there must be some, you totally understand, huh? No? All right, no questions. Euthanasia, and many of you wrote wrote about euthanasia. The term euthanasia means good death. And passive euthanasia is when you allow a person to die, which is not so odd. And if the person is mentally capable, you look for support from them, or you give them the support to do this. All right? Common ways are just to allow to die. There might be withdrawal of nutrition. Nutrition, as we saw in the Terry Schiavo case. Do you remember Terry Schiavo? She was the woman in the nursing home in Florida where they were picketing outside her window. Obscene. The right to life groups picketing. And her husband was, she was on a respirator, and he wanted her taken off the respirator. Remember, this is about 2 or 3 years ago. And there was all sorts of suspicion that he was involved with another woman. Our freedom of speech in this country is a right that we should never give up. But some people carry it out of bounds. And they harassed this poor man to death, and her parents wanted everything to be done to keep her alive. Meanwhile, he wanted, I'm trying to remember if it was a respirator, it might have been just nutrition. He wanted her taken off a feeding tube, I know that much. And even the Catholic Church, that is very pro-life, as you know. I remember during the Schiavo case, CNN News had testimony from a Jesuit from Boston College, and he even said, you are not required to take extraordinary means. And for her, it was extraordinary to continue with the feeding tube. And research has shown, research that was done in the state of New Jersey, over here at University Hospital, by Pat Murphy. She just retired about a month ago. She was a nurse thanatologist, did research over here, replicated many times that if you are in the active process of dying, feeding you increases the pain. All right? It's one thing to moisten your lips, give you ice cubes, but to feed you increases the pain. So the Jesuit, and he looked about 90 years old, but he was right on target, and told it like it was, that those people had no business harassing those who were trying to provide her with a peaceful death. So one way of bringing on death is to stop feeding. Eventually, you die. The other way, we do believe, and if you want to read, well, your papers are done. You'll get it back eventually. If you want to look at the most current nursing policies on end of life, go to nursingworld.com. That's the ANA site. And on the left-hand side, they'll have policies. You click them on. They have policies on all of this. And another way that frequently death is brought on is through sedation. Now, what do I mean by that? We believe that no one has to die in pain. All right? Not with the current state of our knowledge of medication. And unless you've seen people who are in the last stages of life actively dying, you can't appreciate what I am saying. It's nothing to laugh about, to give side talks about. People are in excruciating pain, particularly with cancer, I was going to say, but that's not all. But be it heart conditions where you can't breathe. There's nothing so frightening as some of these situations. But if you give analgesia or narcotics, they can be helped with that and be given some peace. The side effect is that in many cases it hastens death. But even the American Nurses Association and the American Medical Association say that it is a greater good to try to relieve pain. So the ethical principle is the greater good. All right? And if you have to sedate to the point where respiration is suppressed, but you have to do this to give some relief from pain, it's okay. So that is, it's not euthanasia. We're not looking to bring an end to life, but it has that effect. There are euthanasia per se, and many of you interpreted euthanasia as purposeful killing. Some people do. It doesn't matter. But I interpret it as an umbrella term which under it has active, passive, voluntary, etc., all sorts of different physician-assisted, all different sorts of euthanasia. So passive is letting nature take its course. Voluntary, active is really like physician-assisted suicide, where you want to die and you have requested something should be accessed to you to allow you to die. And many of you, well, several so far that I've corrected, have dealt with physician-assisted suicide. Physician-assisted suicide is interesting, and I made a suggestion to many of you, several of you, I don't know how many, that you go on the website of the Oregon Nurses Association. You have to become sophisticated enough to get into all these websites. If it's a .com, many of the .coms are not reputable, but .orgs are usually pretty reputable. The Oregon Nurses Association was the first nurses association to be involved in physician-assisted suicide, PAS. And that was where the first bill was passed. And there are a lot of white papers, a lot of interesting information on there. And one student even clicked on the button to contact and ask them a question. You can do that. Somebody will answer you. But the one concern of nurses in Oregon was that in the legislation which allowed this approach to death, it required that a nurse sit with the patient until they died. No physician, which made me laugh. The physician brought the medication in, let the patient take it, and goodbye. But the nurse had to sit. It's the same thing with execution for crime. There has to be a nurse there. And the nurse has to stay until, and frequently the declaration of death is done by an advanced practice nurse. So what makes me laugh is that if you're executing someone, I get an executioner, like they did in the old days. I don't think you have to worry about sterile technique, that they're going to get an infection from the needle or that you're going to press the wrong button. Executioners probably would do a much better job. That's all they do. And with physician-assisted suicide, I really, for the same reasons, I think you need a person who is very feeling, who can also tolerate emotionally this type of situation. I don't know if you need a nurse. But this was one of the big concerns of the Oregon nurses, because they were being expected to sit and tend in that situation when it was dramatically distressing for them. The Death with Dignity Act, as it's called, has passed in 3 states, Oregon, Washington, and Montana, but it can be accomplished other ways, as you should know by now. We talked about, we mentioned the BSN intent 2 weeks ago. We said that that's the legislation where it's mandated a nurse finish her bachelor's or his bachelor's within 10 years after getting the RN if they didn't have a bachelor's. It's being mentored through the legal process in 2 states, New York and New Jersey. In New Jersey, it's in a committee of the legislature, and it's never going to get out. And in New York, they're changing the rules through the Board of Nursing, so it doesn't have to go for a legislative vote. So there are many ways you can accomplish what you want to do. And you should know this. This is a very important part of political action. You can have a legislative change, or you can go through class action suits, court decisions, or rules and regulations. Legislation is the most permanent, and let's say, has the greatest longevity, because it's so difficult to change legislation. Rules and regulations, though, are formulated by an administrative agency, and you can have a law go through, which is very vague, and then put punch in it through the rules and regulations. And I mentioned to you, in New Jersey, if rules and regulations are not forthcoming within 3 to 5 years, I don't know, I can't remember the exact term, but in a certain amount of years, the legislation self-destructs. That's what happened with the multi-state compact here. But those are 2 ways, the courts and rules and regulations, that you can move your agenda if you don't choose legislation. Why would you choose one versus the other? Why would you choose one versus the other? Come on, someone. You choose one versus the other depending on where you have the best friends. Do you understand? Rules and regulations are the executive branch, and the same thing can be accomplished through an executive order. So if I'm fierce friends with the governor, because he controls the whole executive branch anyway, I'd go the executive branch. If I had fierce advocates in the legislature, I'd go the legislative route. If the top politicians in the legislature supported the bill I wanted to go through, I'd push through there. Declaratory decisions, if I had something that no legislative act that the governor wasn't so hot on, I would go after the people and envelop them in a class action suit. Because if that goes to a high enough court, it has the effects of sort of being law. Now, one of the greatest criticisms of today's Supreme Court is that it doesn't just rule on situations that come to it. It has developed the tendency to make law, the Supreme Court of the U.S. If you go and read and Google Supreme Court, or go into their website, they do have a website, if you go in, you'll notice that there is a lot, they interpret around the edge, and sometimes they interpret so much that they're actually changing the laws for future cases that come up. Because Supreme Court rulings are used in local courts, state courts, to interpret the law. And those interpretations frequently have the effect of changing existing law. Now, in this country, you can appeal the court's interpretation up to the Supremes of the U.S. That is the highest court. You can't go any further. So when you look at why there is such contention, who gets appointed, know that that is above the legislature, above everything, and it's a lifetime appointment. It's a job for as long as you live. It's as bad as being a tenured professor, right? Laugh a little, jealous. Okay. Even though these death with dignity laws have survived legal challenges, but looking at Oregon, the law went through in the mid to late 90s, and over more than 10 years after that, they reported 460 assisted suicides. And if you're interested, you can go on the Oregon Department of Health website, and they tell you the name of the person is hidden, confidentiality, but they have each one of those cases identified. And the point I'm trying to make, this would mean about 30-something a year, right? If you divided it, quick arithmetic. It's not heavily used, the right to die, physician-assisted suicide. It's something that the most people with the most egregious illnesses, pain, have looked to. And they're the most highly educated and the most economically comfortable. Know that. Those are two characteristics. If you go and you look up the descriptive literature, the descriptive research that has come out of this whole thing, every place now. Washington and Montana also, but starting in Oregon. They are a very knowledgeable group and people that have some resources. It's not that they're down to their last penny and they figure they're not going to get services from anyone anymore, so you might as well die. It's not that. The type of people that have chosen this are quite financially well off and highly educated. And the way it's allowed, there have to be, I think, 2 psychiatrists. I don't like the term psychiatrist. We didn't get APNs in there, but it's multiple opinions. To make sure, and physical doctors too, to make sure this is a situation which is terminal, they're suffering, it's a horrible thing to push them to live, and they have a right to ask for this. So it's very interesting, though, even when you have the right, and then there have been many people who were cleared for this, but never took advantage of it. And that puzzled me for a while, until I thought, if you're in this bad way, maybe having the right is to some degree a solace. You know, you have the right to end your life. You may never do it, but you have the right. Psychologically, you can.
Are there any differences between user
And what?
and dignity?
Death with Dignity is the name of the whole act. And under that act, the primary goal is to allow physicians to assist with suicide. All right. Death with dignity means death on your terms. You having the right to end your life when you want. And that's what it's been called in all these states. It's different from the European concept. In Europe, in the Netherlands, and there's one, Switzerland, is it? You can end a person's life without them knowing and going to end. That is true euthanasia. But in death with dignity, as we've chosen to see it, it's the patient asking. So this, well, it's redundant of what I had told you. Most of them were enrolled in hospice. This is just a summary of what was found, and it's important for you to read and digest. But in this country, and I only became, well, I was aware of it, but I didn't understand it until I became involved with a patient the last few months. I have a patient who's dying, there's no doubt about it. But she resists hospice because hospice means well, technically it is supposed to mean you only have 6 months left to live. Ironically, hospice people have found that more people thrive under hospice than die under hospice. If you can accept that, stretch your mind to think about that. In other words, once you're on hospice, all curative drugs are removed. You know that. No more cure. You're given drugs to help you with the pain, to help you with other pieces of the disease that are causing you a lot of anxiety and a lot of loss of peace of mind, but no more cure. Many people, once they relinquish the desire for cure and the expectation that they're going to be cured, which also reduces stress in the family, and family begin to care for them or attend to them with more gentleness, looking at them as equals again, not looking at them as in the death roll, all right? They thrive. The Visiting Nurse Service of New York, they have not published this, but in my discussions with them, they're wonderful. The largest home health organization in the world, Bien-aime, and it was founded by Lillian Walls. Remember, that was one of the matches. The Visiting Nurse Service of New York found that when they brought children primarily onto hospice, took them off hospice, I have to get this straight, took them off hospice, they lived 3 times as long as they were anticipated. And they can only conjecture it's because of the different way you're treated once you're off hospice. Now, this patient of mine, she keeps telling me, I'm not ready for hospice. She kept telling me, I'm not ready for hospice because, and she's a nurse, because in her mind, hospice means death soon. I'm not ready for that. How can I be ready for that? I'm reading a book. I can't get out of bed and run around, but I'm reading a book, I'm enjoying it. I look forward to my next meal. How can I, if I have trouble breathing, which she did, she had cancer of the lung, I reach for my oxygen and turn it on, and in a few minutes I get relief. How can I be dying? So, There's an intermediate program, palliative care. Now, this is not available all over. It's more or less all over in the state of New Jersey, another New Jersey breakthrough. There are other places in the U.S. this is done, but we've become very proactive. It's for people who can't say the D word, who can't accept it. You're given the same treatment to a degree as hospice. Pain is a no-no. So you get whatever you have to take away your pain. Other therapeutics to allow you to live what life you have left. Oxygen. All of these things are given you. What you're not given is the home health aid services. In hospice, it's common for a home health aide to come 3 times a week, perhaps, and there are visits sometimes from nurses' aides or RNs to make sure that your pain is taken care of, etc., everything's done. You're not given those services. But everything else is the same. Also, there's more reticence to admit you to a hospital. In hospice care, it is the philosophy for you to go wherever you're most comfortable. Some people are afraid to stay home when they're in hospice. So there are a lot of admissions to the hospital. Palliative care is primarily thought of as home care, and there is support for the family. All right, so it's a play on words, but there are different services given, and palliative care has become very popular. I asked Pat Murphy, and she's the thanatologist nurse, just like UMD at Chase, why is this? She says, because Americans can't say the D word. You would love her. She's funny, but she's upfront, and often she's crude. But she says Americans can't face the D word. So palliative care, they like that, and essentially they're getting the same treatment, except that there's less use of hospitals and less auxiliary help to come in. Any words on hospice or palliative care? All right, and there is a master's in palliative care, I believe, in southern New Jersey. I will have to look that up, but it was at the point of being established. I believe it has been established. I think it's at Georgieport. Not positive, but I will find out. End-of-life concerns of the people. I think that's very important to look at. Loss of autonomy. The sicker I get, the nearer I am to death, the more is the chance that I can't speak for myself. All right? Loss of dignity. Decreasing ability to participate in activities that make life enjoyable. One patient said to me, this was several years ago, an older gentleman, he said, listen, I've done everything I want to in life. I've made amends with everyone I did wrong to. And it's so I'm comfortable with going. He said, let me cross the river Styx. Do you know what that means? The river Styx in mythology. The living were on one side of the river, the dead on the other side. So he wanted to cross the river Styx. Okay, transplants. You should know a certain amount here. In order to harvest an organ, you have to verify the person's wish to to donate, and this is usually from the next of kin. Your driver's license, signing that, is an indication of your desire, but there will always be an attempt to get verification from the next of kin. And if you're underage, they can't do anything without having the next of kin support the action. Although, if it's critical, and if you can't get the next of kin, you can always go to a judge. Judges have infinite power and could give you right to harvest if you can't get the next of kin or if there is no next of kin. And I hope all of these judges have had a course in ethics and healthcare and know what is the latest in healthcare and in cure. I wonder sometimes, particularly in places where judges are elected. You know, you don't even have to be an attorney to be a judge, you know that, right? And so where they're elected, it could be a purely political thing. And when they're confronted with these type of decisions, it makes me ill at ease. All right, there is a uniform anatomical gift law which determines where the rights lie to verify, etc. But there is also other laws which cover transplants, and you should review them in your book. We have a national bank for transplants, so that you can designate that you want to give your organs to specific people. But in hospitals where they harvest organs, a certain percent of those organs have to go to the anatomical bank of the United States. And they don't just sit there for years waiting for someone. You know that transplanting has to be done with most things spit-spat very quick. They can't lay around. So that if you're waiting for a transplant, your information goes into the federal bank. And they're connected all over the United States. And when a gift of an organ is received, there's a look for a perfect match. And that's why you frequently see medical personnel traveling. Have you ever seen them get on planes with a little white case? And because they will fly that organ wherever it has to go. I mean, quite an unbelievable process, what we do. And we still do not have enough organs. Now, I should have someone in to talk to you about it, but I don't think you can afford a whole session talking about transplants. The important thing for you to realize is there's no one better to talk to a family about transplants than a transplant nurse. And you have, for instance, Beth Israel down here in Newark is a transplant center, and their director is an APN out of our program. She's magnificent. She knows how to approach people, how to explain to them, how to be sensitive to cultural pieces and religious pieces that I don't feel anyone, even the transplant surgeon, would have the sensitivity that she does. She's been doing it for many years. She's not looking to go anywhere else, and she's developed this proficiency. She would tell you that in places that do a high amount of harvesting, a certain percent of their harvested organs have to go to this national bank. But if they do an exceedingly high amount of organ harvesting, they have more organs available to people who are there. One of the largest services in this area is Thomas Jefferson in Philadelphia. They harvest a dramatic amount, make their contributions to the National Bank, and still have an abundance of organs. And if you talk to them down there, they'll tell you, we don't wait for the cases to come in emergency, we go out and look for them. I didn't ask for more elaboration. They didn't mean nabbing people and taking out their kidneys, which you know there have been cases. You've heard of these cases? In New York, people found in Central Park with one kidney and a surgical incision. It's absolutely reprehensible. Some of the conditions that people will tolerate to sell organs or to get an organ. But Jefferson has the largest population of harvested organs that I know of around here. And I think I told you at the beginning, of course, I had a patient who was 10 years on a waiting list here in northern New Jersey, went down to Jeff, although he didn't want to go and have the test done again. In a month, he had his organ. And he was only there 2 days. They're experts at this. So transplants have gone a long way, but we still have a long way to go. But the people who work on these units are the best people to ask family to donate, because many people are still reticent to donate. And the mentally ill and disabled, their rights, we talked about that. Go back to the Mental Health Acts and to the Shame of the Nation, done during a study during the Eisenhower administration, which first described to the American people the way their mentally ill were treated, and it's still there. Believe me, people, it's still there. We changed their rights in the law, but there's no places for them to go. Confidentiality and privacy has become a big issue. We've talked enough about that. The HIPAA laws, protects only health records transmitted electronically. HIPAA is, people like to sound smart. They talk about HIPAA and confidentiality. It's only about electronically transmitted records. And the Freedom of Information Privacy Act is older than HIPAA. There are exceptions. Communicable diseases have to be reported, some of them. Gunshot wounds and criminal acts, including rape, must be reported. If your best friend comes into the emergency room and you're working, and she was raped out in the street, and you want to, there's stigma associated with a lot of that still, and the fact that it will probably go to court, and particularly the woman is always painted as encouraging the encounter. You want to save her from that, you can't. It's reportable to the police. If the Queen of England walks in, it's reportable to the police. Abuse and rape, all right? Abuse, child, spousal, and elder abuse and abandonment, and know that abuse doesn't have to be physical to be reportable. It can be physical or reportable or verbal. It's still reportable. And AIDS, in some states, this goes state by state, it's a very controversial issue, but in some states, they require the carrier and exposed partners both be reported. All right? How would you know? Well, unfortunately, the place you're working, if they have high incidence of these situations, will tell you, but it's really your business to know what the laws are. So if you see that you're working, particularly in an emergency room, and there are a lot of undiagnosed AIDS cases coming in, you better get your fingers on that computer and find out what the state laws are. Because you're responsible to practice by state law, even if no one tells you. I want to emphasize that because some nurses feel, well, my boss didn't tell me. That's no excuse. Another thing that you should get in your mind very clearly, there's a difference between confidential and privileged communication. Privileged communication is the communication between doctor and patient, lawyer and client, clergy and communicant. All right? They're recognized in the law. And communication between an APN, advanced practice nurse, and his or her clients is seen as privileged in many states, not all. But the communication between an RN and his or her patients is not privileged. So, let's act this out a little. You're working in emergency, and two people come in from an auto accident, and they're of age, they're say 22, 23, and the one person they're both seriously hurt. The one person is conscious and has lost inhibition, which happens frequently. Some people have no inhibition regardless. Other mature adults have inhibition. You don't just spill out whatever you're thinking, like diarrhea of the mouth. That's what I call it. You think before you speak. But often when there's trauma like this, there's a loss of inhibition. And the one patient coming in on the stretcher starts talking to you about he shouldn't have made that turn. He knew the light was against him, but he saw no traffic. And then the cop comes in and is telling you about the accident report. It seems the two drivers switched places. The two guys switched places, which is not uncommon, after the accident to avoid prosecution. All right? You have that information. If asked, you have no privilege to say, I'm privileged. I can't share it with you. You have to honor the fact that whatever information you have has to be given. You have no privileged communication. Privileged is when you don't have to speak. And privilege for a doctor or a lawyer or a clergy, realize that privilege does not cover everything. It covers only the issue about which you're talking, the issue in contention. All right? We have more and more declaratory decisions about privilege for APNs, advanced practice nurses. And in some cases, there have been a few decisions that award privilege to psychiatric nurses, which makes sense to me. It might not to other people, but psychiatric nurses are told some of the deepest, darkest secrets. And if you can't promise the patient, this is just between you and I, it'll never go any further. And if I feel it would be to your welfare to tell someone else about this, I'll talk to you first. That's how you describe not having privilege. You know, I do not have privileged communication, but I will hold your words in confidence, and if I have to share it with someone else, I'll talk to you first. That's how you explain your situation. But, here, I didn't realize it was here, psychiatric nurses particularly have a responsibility to warn their patients about this. Assault and battery. Assault and battery, just listen and know the difference. Assault is any attempt to use force or violence with the intent to injure, the intent. But battery is when you actually do it. Think of it, make up a mnemonic for yourself. That's sort of good here. A and B. A, assault, B, battery. You threaten someone before you actually go after them and hit them. So A and B. And you can be charged with battery if you touch or handle roughly, through no fault of your own, a patient. There have been nurses who have been brought up on charges of battery. So you have to be careful to document and to ask the patient the permission to touch them or to perform procedures. I want to do this now. Do you understand what this is about? I explained it to you earlier. Yes. All right. Then you go on. You just go in and start to touch a patient and pull them around. You can be accused of battery. There have been many cases, most of them settled out of court. It's a nuisance case. A lot of times, no matter what you do, you'll be accused of something. It's not common, but it's frequent enough that you should know the difference. False imprisonment is another interesting thing. There are pretty recent federal requirements under Medicare. And remember the model I described to you. Medicare is for the federal government, but it trickles down to the state. And in New Jersey, it's there for Medicaid and for all other private insurers. Everything. It's one thing that really does come to us from the federal government. And one thing is the use of restraints. In order to use restraints on the patient, you need a signed order, and in most places, it's from the doctor or to a lesser extent, but also fairly common, the APA. You need a signed order to apply restraints. And if you do apply restraints, you better quickly try to calm down the patient, either through drugs. I'm not a big proponent of drugs, but sometimes when people are super anxious and acting out and become violent, it is the only thing to protect them. But you want to do it fast because there are rules for application of restraints, and in most places, you have to release them every 10 to 15 minutes. Why? Because if you cut off circulation and with a patient resisting and the circulation, the places restraints are put, you could very easily cause permanent injury. All right? So you cannot apply them without a written consent, the doctor, or in some cases the APN. And it is immobilization of a body part, and detaining an unwilling patient in a healthcare facility because you want them to pay the bill or something of this type is restraint. It is false imprisonment. It is restraint. If you have a patient who wants to go home, they can be signed out, AMA, against medical advice. That's common. They have to sign themselves out. But if you feel it's unsafe and you're making excuses to hold them until their doctor comes in this is play acting, until their doctor comes in because, the two of them have a close relationship, and maybe she'll listen more carefully to the doctor, and she's screaming she wants to leave. You have no right to keep anyone. You let them leave. Now, in extraordinary situations, you could bring a restraining order to a judge. Let me tell you, not even a judge today is going to sign these orders. I know if you watch Law and Order at night, they're always going to the judge, sign this, sign that, and the judge is taking their word for it, not in reality. Because to, in any way, restrain the freedom of a person is setting yourself up for a legal suit. All right? So you can't detain anyone against their wishes. We talked back and forth about abortion, and abortion, in fact, in this country has become de facto illegal. Now, listen to me carefully, because I'm sure some of you don't. I see the things coming up in your papers that I've mentioned 100 times. Abortion is legal because of Roe v. Wade. And there's the constant attempt, and Roe v. Wade was 73, and it said that the first 3 months of pregnancy, and the arguments were that the child cannot survive without the mother, but the mother has a freedom of choice. Putting it simply, that was the case. Now, there were subsequent Supreme Court cases. Webster, in '89, gave the states authority to limit the right to abortion. And the states limited the rights in different ways. In some states, you have to notify the father. In some states, you have to notify the parents. All different ways that the government has intervened to limit the rights. There are so many. Now, who was it last week that a governor submitted legislation in their states to further limit abortion? Who was it? Anyone listening to what's going on in the world outside? I think it was Texas. I think it was Perry of Texas, who is a very good governor. It's the only state running in the black, Texas. Only state running in the black. Despite the fact that it has dramatic problems with immigrants, cross-border activity, everything else. But he's a very conservative man, and there was a piece submitted to the legislature in Texas to further limit. Late-stage abortion has been another bone of controversy in recent years. The use of procedures to abort a baby that could really live on its own. And there are certain techniques that are used. So abortion, although we don't hear as much controversy as we did a few years ago, is still very much a hot item. And in many places, although it's legal, it's de facto illegal. What does that mean? It means the fact of the case is there are so many limitations that no one can take advantage of. All right? And I don't know what to say about where it's going to go. You know, it's not taught in medical schools anymore, abortion. It's offered as an elective, if you want it. And the last of the physicians who were advocates for this are getting on in years. The New York Times had a big feature a few months ago on a physician out in Wyoming who flies into the most secluded areas to perform abortions because he feels it's the moral thing to do. And these patients cannot get to anywhere in civilization. So he flies his own plane and goes into these areas to perform the procedures that are needed to be performed. But there are less and less physicians. You may or may not remember the Boston bombing cases, the Planned Parenthood clinics where abortions were offered to be bombed some years ago. That led to a Supreme Court decision that you cannot picket within so many hundred feet of the door of the abortion clinic, and you cannot harass people who are going in for a procedure. It's a shame we needed legislation to protect those type of rights. Some other, another very sad situation was the gag rule. The gag rule was a law that was passed in '91 and subsequently removed by President Clinton his first day in office. You have to respect that man. So his first day in office, he did what had to be done to fulfill campaign promises. One was gays in the military, don't ask, don't tell. It's a generation before what we have now. He signed that the first day and removed the gag rule. Since '71 to when he became president, '93, no health care givers or providers in institutions which received any federal money, any federal money, could mention the word abortion. Not even to say, I can't talk to you about the full range of options you have, but if you go to Dr. So-and-so down the block, his nurse could talk to you. Any insinuation of abortion or use of the word and the federal monies to the Planned Parenthood, to the clinic, to the hospital were cut off. Absolutely insane, because as a healthcare provider, you have the responsibility to educate your patients, to tell them what's available. You don't have to participate in it, but they have the right to information. So, what happened in the midst of this, you saw all of the provider professionals leaving their jobs in Planned Parenthood. It was a real crisis, and Clinton removed the gag rule with an executive order. And remember what that is? That's when a governor or a president says, the heck with all this legislative process or rulemaking, I'm going to take the bull by the horns and I'm going to make something happen. Now, the legislature could have appealed his decision. They didn't, which to me said there were more people sitting in that legislature that wanted this to happen, but they felt they couldn't speak out because of their constituency. So if you have a president that's going to do it, just shut up, let him do it. Very interesting political analysis. And some hospitals refuse on moral rules. I'm sure St. Michael's isn't engaging in termination of pregnancy, and that's what it's called, not abortion in hospital. It's TOP, termination of pregnancy. But on religious grounds, they are legally exempt. partial birth abortion is the term for aborting a fetus. It's not an embryo anymore, a fetus, who is significantly past the point of viability. And partial birth abortion is legal in New Jersey since Christie Whitney. I'm not saying it's right or wrong, it just is. Sometimes the partial birth abortion is to expel a dead fetus from the uterus. All right? It can be a dead fetus. Feti die in utero, and they have to be expelled somehow. And other things which are linked, the objections to sex education and condom distribution, that has been a regular discussion. Other reproductive rights that are related, and you know that there's controversy around all of this, chiefly because religion has become entwined with the issue. And I don't know if it should have been, I mean, we could have a real good debate on that. Should religion ever have brought into it? Or is religion between the communicant and their confessor? Should the decision be made at that point, or between a woman and a man? Should government become involved? This is a real, you remember, we come from the roots of being a puritanical country. A lot of things are legal in other countries that are not legal here. And you might think, my heavens, that is odd, particularly people who have immigrated here can't get over this. Why you're so liberal in some ways and in others, we're on people's back. We have problems with obesity and tension and other things in this community. Yet, when you talk to the people in business, the business literature will tell you the most productive people on the face of the earth is the population in the U.S. We're dramatically productive. And if you go look in other countries, they retire mandatory at 55. They give them a broom to sweep the streets. But here we have a very alive and well work ethic. And here are some of the other reproduction-related rights. Sterilization. Sterilization over the years has had a track record. Criminal sterilization, sterilization of pedophiles, chemical sterilization, you all know about that, right? Often someone who has been convicted of repeated pedophilia is sterilized chemically. It can be reversed, but they are required to receive injections, supervised injections, to sterilize them. And it does more than sterilize, it decreases the libido, takes away the urge. Wrongful birth, a big area of court cases today. It is very common to have genetic testing before birth while a woman's pregnant. Either through the cilia, it can be done very early or it can be done later. If it's amniocentesis, that's when they put a needle into the uterus and draw out fluid. That's about 5 months. You're getting on the border with the time you have to terminate a pregnancy. But there are many doctors, less than they were years ago, who play God and take it on themselves whether to share the information. Let me emphasize, much less now, but still you see it. And a wrongful birth is a birth where a child is born that parents would have chosen to abort if they had known. child had the problems that they had. It's someone else's decision, not for you to decide. A very big area for nursing, too, genetic counseling, which of course takes advanced preparation, very challenging. Artificial insemination and surrogate motherhood. I have two partnerships, people I know very well. They're both gay, and they're both having children through a surrogate. This is very common, particularly in England. In the U.S., there's a healthy fee associated with this. All right? You pay significant to hire a surrogate. In the UK, it's illegal to pay a surrogate, except for their maintenance, food during the period of the pregnancy so that you eat well, so that if you're on limited income, you're not in any way depriving the baby. Maybe a place to live in if you are that poor, but you're willing to have a child. And there are non-governmental organizations that meet to get the people together and guarantee that you know each other before you enter into this arrangement. And you cannot formally adopt the child to 6 months after delivery in the UK. To give the surrogate time to think about it and to get back into her normal life and see if she wants to put a claim. I don't know how I feel about that on the child. But very different situation. In the U.S., I would say a surrogacy of one child probably is $40,000. And there are attorneys who are experts in surrogacy now, very burgeoning area. And I don't know of anyone that has gone into this that didn't have a reason. I know of 2 people who went in because they had chronic diseases and were told that they ever had a pregnancy, they would lose certain function. And I don't want to say too much, but and for that reason, a couple searched out a surrogate, and there are good people out there, but they're compensated heavily in this country. Difference in philosophy. Okay, any questions about any of this? And yes?
So in the UK, the surrogate can choose to keep the baby?
Yes. And that leaves me uneasy. In the U.S., 2 people I know who use surrogacy, as soon as the woman went into labor, and this was all stipulated before in contract, as soon as she went into labor, the natural parents were called. I have to think, separating all these terms, natural, birth. The natural parents were called. They went to the hospital. As soon as the baby was born, it was, if you're familiar with the position for delivering, you can't see, your view can be blocked. The baby was taken to a pediatrician who was there, a cord was cut, and the baby was taken home. Several states away in one of these situations, immediately. The birth mother, but of course it was not her egg, it was not anyone she knew sperm. Understand, she was a vessel. And as soon as the baby was born, it was taken away. There was an agreement that she would never see the baby. I think once you allow some caregiving, I I don't know, the baby doesn't have to stay with the person, but she has a claim in the UK. And I think you get into, unless this person was very clear on the expectations, and these are, it's been described to me in the UK because there is no large money transfer. It's very altruistic. So unless you're very altruistic, you build up a bond, I would think, of some type. All right? Okay. We talked briefly about genetic testing and how New Jersey is one of a handful of states that does routine genetic screening at birth. Screening does not tell you what's wrong. It tells you you better look further. There may be something wrong. And the rights of students is another right of humans that you should know about. You always settle a grievance as close to the place it happened as possible. If you have a grievance with your grades, come to me. We'll try to settle it. I harbor no bad feelings in any student. I put a lot of thought in grades, but we try to settle it here. Then, if you can't settle it here, you go to the next in command, which with me would be one of the associate deans. Then, if you're still not happy, you can go to the dean and you can go to the grievance committee in the university. And every university has different rules for grievance. Rutgers has very fair rules, and students can be represented in the school grievance hearings, and both parties present their case. It's very fair. In some universities, it's not so fair. There is no opportunity for the student to be represented. The case is just put out in front of the grievance panel. So it's important, not that I expect you to have a college life full of grievances, but it is important for you to know. And you have the right to access to your school records. Those have been guaranteed since 1974, the Buckley Amendments. That's Robert Buckley. He was a senator from New York. Okay. Any questions on the rights of people? There is so much here. And know that over the past years, in recent years, well, let's say the past quarter of a century, we've become more and more dependent on legislation to protect us. And whether that's good or bad, that's another thing for debate. There are people who say things would be facilitated much more and much less expensive if we could settle disputes among thinking, feeling people. And there are others that say, no, we need the rules for everything. So, but we have developed more and more rules in this country. And I guess the only way is some of these countries that have monarchies, true monarchies. I don't think the UK is a true monarchy anymore. They just support a queen to have her there. But if you're a true monarchy, you're told what should be, and you accept it without question. And that's what a lot of people who migrated to the U.S. were running from. Like my father used to say, he didn't come here because he had it so good in the old country. And when you hear more about that, you know, indeed, it was they had it bad. It's not that he didn't have it so good. So, any questions? Why don't you take a 5-minute break, 10-minute break. As soon as enough of you come back, we'll start again.
calories.
Yeah, for all ages and stages.
Yes.
Which, and it says like it's against which overruled this.
Federal judge. Now it becomes a question of whose rule is going to prevail. I'm hoping that by early this week, I'm busy most of part of the weekend, but by the weekend. All right?
I was making a mistake for the Thursday. I sent it to somewhere else.
For what? Okay.
And
Send it again. Okay.
yeah, I emailed to you. I think it's March 25, and the same day I don't know before. So I come in again, and I think this week.
I don't know. I don't look. If it says paper, I leave it till I can get it.
Oh, okay. I just think maybe you think I prepay and already over. But I
If you want to send it again, that's okay.
already sent it to
Gone.
you.
Yeah, I did.
25, and I come in again. The first time I come in is the 25. Also, I don't know. I made a mistake, and I do that again. It's okay.
Maybe it's not your mistake. Maybe it's the computer system. Don't worry. I know you. I go to psychiatrist. All right.
Thank you.
How did you like the second copy of it?
Oh, wait a minute. I sent back.
Yeah, how did you like it? I saw your comments, but
I think you're in too deep. I don't think that any place. All right. See, there are alternate practices to cure illness, alternative and complementary. That's what the government calls it. There is biophysical, and then there's biopsychosocial. I don't know of anyone today in this country that doesn't use chemistry. And to try to establish a demarcation between them, I was getting a feeling it was artificial.
what, like my explanation between comparing? Okay.
Nobody can look at any sick person and make it purely biophysical and ignore even the ultra specialists. They may make some very commonplace suggestions. Tell you, listen, you're going to have to get your lifestyle under control before any doctor can help you. They won't do it, but they'll say those things.
Okay. And that's like, you think all doctors? Because I feel like some of them would just disregard it, and that's what my point was.
I don't know.
Okay.
But you didn't do, it's not a research. You didn't survey doctors.
True, that's true.
And your readings, none of them was descriptive enough either. Now, did you send me the final one?
No, I'm sending it today.
Okay. You can even take till Monday with an back on everyone else. No one else has asked you. Anna, she made a mistake in how she said, all right, look, if you need the hard case, but I can't react to another paper.
No, that's, I understand.
No, it's not the time. I make time if I have to. But it gets to the point where when you react to too many, you're practically writing a paper.
Right. No, I understand, but I appreciate you sending it, like,
No. And you're a good student. You do very well.
Thank you. And then I just had a quick question about like some of your comments. When you said it's not here, what did you mean?
Oh, you're starting to make this laundry list. Stop here. Don't go into a laundry list.
Okay.
Physical causes, virus, bacteria, injuries, biochemical imbalances. There's functional inadequacy. There's a million things.
Okay.
Okay?
So just don't.
It was a suggestion
Okay.
that you dig in your grave deeper.
Okay.
As you,
Okay. So just like 2 or 3, because I wanted to like explain it almost like after you.
you don't need it to explain.
Oh. Okay. Okay.
It's a think piece for you.
Okay.
All right?
All right. And then I have one more. Yes. For this one, what you said, put the psych and social always there.
Yeah.
Yeah, I thought that.
You don't make it a choice and exclude them. You can't. How can you exclude them?
I don't know. I feel like sometimes when patient care providers are providing like patient care, they don't take into consideration like when they're educating the
Oh,
patient.
all right. Healthcare provider starts their education by asking the person what they know and how they feel about the disease. And then moves from there.
Okay.
To think that any healthcare provider can be culturally competent for every patient is ludicrous. I don't care about this course. You have to make sure you understand where your patient's coming from. That's right, Mike.
Okay. Okay. All right. Thank you. I will send it to you.
All right. When you get
Okay. And then when I put it in, initially on turning it was like 2%. So that's.
it's not. One less problem.
Okay. All right, let me share some dates with you. I just last night got the date of the final exam. It's May 10th, 11:45 to 2:45. I asked for this room, but that doesn't mean anything. We may not get it. I just would like this room because it gives you a lot of space. All right? So it's May 10th. I will put this as an announcement on the website, too, in case there obviously are some people that aren't here. And in addition, the first reading day, May 7th, it's Tuesday, I will give a review. 10 o'clock, this room. Okay? What? Tuesday, May 7th. May 7th is a reading day. Tuesday and Wednesday. Tuesday, 10 o'clock, this room. So no one should have anything unless some other professor's giving a review, then it's your choice. All right? But I can't emphasize enough.
But I have class
No, you don't. It's a reading day. It's illegal.
There's a Tuesday classes, okay, so?
Well, I don't do it. It's the university. The last class, all right, let me look again. The last class is Monday the 6th. The last class. Boom. Finished. And 7th and 8th are reading days. You always have 2 reading days. Last year was an exception. I don't know why, but you only had 1 reading day. And I got this room for 10 o'clock on the 7th. So I've never done a survey of people and whether those who came did better, but I suspect they did. So come if you can. And we'll particularly emphasize the second half of the class. And I will put a blueprint up before. As 100 questions. Most of the questions are on law, ethics, and the rights of people. All right? Law, ethics, and let's say legislation. I haven't put it together yet, but by far the most questions, all right? Those are the functional pieces that you have to understand. All right, let's very quickly look at nursing practice and the law. Next week we'll go more into the law, and we'll go and start ethics. Ethics is very important. Ethics is not the law. All right? You are required to act legally. You are acculturated to act religiously. But you aspire to act ethically. There are ethical principles that you have to apply constantly in your behavior, but it's something that comes from deep down within you. It's not the law. All right. Let's look at the law, though. A lot of discussion these days about the large awards, and most medical legal cases are settled out of court. There's a lot of criticism of the legal system, lawyers making big money. There may be a few, just like there are a few doctors making big money. Am I right? But medicine is not the place to go to make big money anymore. You do know that, all right? Physicians, more than ever before, are employees. And there are all sorts of relationships that exist. And it's not a course in that, but you should know that. Like a lot of physicians work for hospitals. A lot of them work, for instance, most hospitals have physicians on duty round the clock now. Intensivists are physicians who work with intensely ill patients in critical care, etc. And their competition is the APN. Advanced practice nurses do the same thing. Now, who's better? Your guess is as good as mine. All right? We're still a country that has been medicalized. In the UK, 93% of all babies are born by a midwife. Surrogate mothers go to a midwife. No one sees a doctor unless there's a critical complication of pregnancy that comes up. The U.S. has adopted the physician model, and still, even though we have some people who use midwives, it has not become the method of choice in the United States, okay? And there are a lot of people think that all doctors are rich. I know of, at least 10 doctors in New Jersey that have retired this year because what they were bringing in was not supporting the overhead in their practice. And there are others who are doing well, but it's not a foregone conclusion. And law, not every lawyer. There are too many lawyers. You all know that. If you're reading the Times, I know one of you is reading the Times. You brought me up an interesting thing. Where are you? Yeah. Tell them what you found in the Times today.
It was just saying that the judge,
Supreme Court. Yeah.
allowed over-the-counter over-the-counter pills for all ages instead of just 16 and above.
It's a decision that went to the Supreme Court on access to the next day pill. And the Supreme Court said everyone should have open access. All right? This flies directly in the face of Obamacare, one of the provisions in Obamacare. So what will happen, since you can't go higher than the Supreme Court, Obamacare will have to be amended, or they'll seek an expanded interpretation of the Supreme Court's decision. All right? But as we have more clarity in law, you'll need lawyers less. And right now, if you go to a lawyer with a medical malpractice claim, almost all of them will take it pro bono until, if they think there's a case there, a recovery, they'll take it free. And then they take a percent of the recovery. That percent is high, but some of these cases require that lawyers work on them 5-6 years, you know. It's not settled overnight. So if they really scrutinize the case carefully, and if there's no hope for winning, they won't take it. Of course, a client can always pay for the services, but they discourage going on. And if they do, they charge a healthy piece of the recovery for their effort. But most cases today are settled out of court. Insurers find that the cost of legal fees and court fees, with those costs, it's easier for them to just settle. And so they'll do that. Now, that increases the cost of health care because there are a lot of people who come in with nuisance cases. Those are ridiculous cases, in the hope of making a few dollars. I mean, that may seem far from what you're used to, but it does happen. And that ultimately increases the cost of insurance, et cetera, all right? But most doctors today, many doctors, are working for companies or hospitals, because that way often the employer picks up the cost of their malpractice insurance also. Nurses are insured in hospitals, home care agencies, nursing homes. For state approval, you have to have insurance to protect the customer. Who wants to go to a hospital where they can do anything to me and I have no right to sue? So you have to, or no possibility of getting any retribution. So you have to have insurance, but a nurse should never rely on an employer's insurance, because the insurance is there first to protect the employer, not to protect the employee. Your second thought. And there could be some very serious ramifications if a case is found for the injured person and your name is on it. So some of the complaints with litigation are the large awards, the impersonal relations are a factor. The AMA has done a study on the degree to which physicians are sued. And they have found that as specialization increased, so did suits, grievances against doctors. In other words, as you move from the model of the primary care doctor, and now the APN can serve that, but as you move away from that, care becomes more impersonal. It's rare that you find a person suing their good old family doctor who delivered them and is taking care of them since they were a little kid. There's a tug at your heart. You don't want to sue that person. But the specialist, right away, you sue them because they should have known better. So interpersonal relationships are a big factor. And tort reform is on everyone's lips, looking, and there has been talk by the Obama administration of seeking tort reform on a federal level and imposing it on the states. And remember, I told you the danger of that. It'll never get through. No one who's elected to the legislature wants to stick their neck out and vote for anything that's going to be forced on their constituency. Because whether you realize it or not, this country is very committed to states' rights. So everyone sees things differently, and they don't want big government forcing them to do things. But that's part of what the president wants, is tort reform at the federal level. What are some of the tort reform provisions that have been talked about in New Jersey and have become law in some places? Limiting non-economic damages, pain and suffering, lack of consortium. You know what that is? That's inability of a woman to have intercourse with her husband. Big money's in that. Lack of consortium. And pain and suffering. What is pain? I think I have a high tolerance for pain. I know some other people that they stub a toe and they're screaming. So whose pain deserves more money? Suffering. What is suffering? These are all nebulous things, but have been talked about ways to limit. There are some states where pain and suffering is disallowed, just because of that. Limiting attorney's fees. Attorneys are a slick group. They control their practice through the Bar Association, and they all want to. If you have a gripe with an attorney's fees over their ethical conduct in representing you, you bring it to the Bar Association. That's their professional association. And they're tough on each other. They have ethics committees that will hear the charges and your appeals. They have a slate of fees, customary and usual. But the rule is charge what the traffic will bear. You're doing something for a gazillionaire, you charge gazillionaire prices. You're doing something for someone who is teetering on the edge of survival, you may even do it pro bono. It's up to you. So they steered clear of using legislation to forge their profession. Requiring the loser to pay the court costs, that's common. In other words, if particularly if you brought up the issue and initiated the fee and you lose, you pay for it. Joint and several. Joint and several is the term used for what is in slang called a shotgun approach by attorneys. A shotgun approach means if I was in a hospital and I was hurt and I get an attorney, that attorney has me sign for access to his records, and every person who signed that chart is sued right off the bat, because somebody is going to have what they call deep pockets. And the physician is usually seen as the one with deep pockets. What is deep pockets? Either they have money or they have sufficient insurance to pay big money in a settlement. Okay? Joint and several. There are many states, and I think New Jersey is, well, no, forget that. But there are many states who have eliminated this possibility. They say you can only put on as a defendant someone who was involved in the injury, very closely involved. none of this, everybody, in. And then if we prove the case, we'll get a little from each. Statutes of limitation, everything has a statute. A woman called me up a week ago, 2 weeks ago, and I sent her to a malpractice attorney, and she had waited too long. There was a statute of 2-year limits on going to court over the, all right, what was the situation? She was treated by a physician in a less than stellar hospital. Now, why do I say that? Because the best hospitals are very judicious about who gets privileges to practice there. This physician never even had a chest x-ray taken before major surgery. And every place I know of, an EKG, a chest x-ray, and certain blood work is common. It's called preoperative orders. Never had it taken. Well, lo and behold, 6 months after, no, 3 months after, she was diagnosed with cancer of the lung. And it was a stage 4, which is very progressed. It was the opinion of physicians that that had to be there when she went in for the surgery. No cancer would have progressed that much in that short period of time. And she thought about it and discouraged people from using the same physician. But finally she was told, you really should bring this to the courts and get this physician off the street. And by the time she decided, statute of limitations had run out. So those things happen. And statute of limitations for children starts after they reach the age of majority. Alternate dispute resolution or mediation has grown dramatically in its use. Nurses, I know, one of the ADR, alternate dispute resolution, that's the acronym for it, is people are trained in this. They don't have to be lawyers. I know of at least 5 nurses who have gone. One of the biggest schools is at Harvard. It's not a degree. It's a course. And they give you a certificate. And I know of many nurses who have gone up there and taken this course and are working in this area. Sometimes it will be lawyers that go. You need some basic concepts of the law. But nurses do very well because their interpersonal skills are highly developed. And what you're using a third party to try to bring together a plaintiff and a defendant and have them settle on something out of court. Again, it's much cheaper than court costs, and it can be done very expeditiously if you have thinking individuals. All right, the litigation history of nurses. You can read this. But it's enough for you to know that the claims history of nurses paid, that's when money is actually paid, is 1.8%. We're clean. And in public opinion poll after public opinion poll, and I've mentioned this to you before, go to Gannett, go to any of the public opinion polls, Quinnipiac, the Institute for Public Opinion on the New Brunswick campus, which is part of Rutgers. It's funded through Rutgers. Nurses have been seen as one of the most trustworthy people in society now for generations. In other words, people trust us. The only time there was anyone that exceeded our scores by the public was right after 9/11. Fire and police were seen as the most trustworthy. It's interesting. But people see nurses as very trustworthy, as not operating in our own behalf, of being people they can look to who are advocates for them, which I said is the most important role, you will assume. So we have a very low rate of suits and even a smaller rate of claims, 1.8%. And 64% of the nurses involved are RNs, not APNs. And APNs are the ones that can do the procedures, give the medication. They have a more technical or a more complex medical role, but they're not even the ones who assumed the most. Of RNs, predominantly obstetrical and surgical cases, the most commonly sued are OB nurses, without a doubt, OB nurses. And the most commonly sued physician is the obstetrician. Why? Because everyone thinks they should have a perfect baby, I'm being facetious here, with no problems. Or everyone thinks it's such a normal process, and it is a normal process. When anything goes wrong, they're very willing to sue. If you look at other people that are sued frequently, orthopedists, not orthopedic nurses, but orthopedic physicians have a heavy suit history, and neurologists and neurosurgeons. They're dealing with very technical, complex areas. But our suit history is almost pristine. Now, what is it going to cost you? What does it cost you for your student insurance? You have to take that, right? You have to, yeah, before you go into clinical. Do you know what it'll cost you yet? No? As an APN, mine is $2,000 a year. I'm sorry, that's not much. Nurses are cheap, too. You know, honest to God. The most important thing you can do politically is give to your candidates. And if every nurse in the U.S. gave $100, every working nurse, not students, every working nurse, gave $100, we wouldn't need a legislation to give people money to run. We could elect the president. But nurses aren't cheap. Your insurance will be in the hundreds. Something wants to tell me 200 and something. As an RN, you have a cheaper rate as a student, but it's minimal. Especially when you consider that as a new graduate in a unionized facility in New York, now there's a big difference between New York and New Jersey. A lot of you want to stay near home, the crazies among you, want to stay near home, but in New York, you can easily make $100,000 a year. So don't cry about the 200 for your insurance or 300, but you need it because the employer will protect themselves. If someone is going to have to go down in a blaze of glory in a suit, it's not going to be the physician. It's going to be the nurse. All right? Because you're expendable often. I mean, there's still this attitude. But our claims history is wonderful. Our insurance is low. And the first thing you should buy when you get out of school, get your RN and buy insurance. All right. The elements that have to be present for you to have a negligence or malpractice case are these four things: duty, breach, damage, and causation. Write those in your head. Duty, breach, damage, and causation. Duty. you have assumed the responsibility for care of your patient. If you come on the unit and you don't assume responsibility for care of someone, they're not your problem. In order to get sued, you have to assume responsibility for care. Then you have to have failed to adhere to the standard. Now, what is the standard? Read your book. If you have a case that goes to trial, or to a judge, or to an administrative hearing, the first thing they're going to want to hear is from a witness who is involved and can speak with authority about the standard of care. Like the example I gave you before, it's medicine, so it's a good one. I would bring, if I were taking my friend's course, my friend's case to court, and it was going to come up before a judge or whoever, and I was working with the attorney to develop a list of witnesses. I want some people who have spent their whole life working in surgical nursing and were absolutely eloquent on what pre-op tests were done. When Mary Jones, 50 years old, gets up on that witness stand and says, I've worked in Sloan Kettering, and I'm one of the best places, Sloan Kettering, for 20 years, all the way from staff nurse to supervisor, etc. I've never seen a person scheduled for surgery without having a chest x-ray. That's it. Who's the judge or the mediator going to listen to? These people have to have credibility, which means they have to hold leadership positions, be in leadership positions, leadership organizational positions, hold prominent positions in caring institutions, but they will give testimony about the breaches, the failure to adhere to standard. Damage. The injury is proven. That's why it's so hard to get recovery from pain and suffering. Who sees suffering? Well, I was writhing in pain all night. Now I can get an actor to writhe in pain. You don't see it. You have to be able to prove the injury has happened. And causation, the injury is directly related to failure to meet the standard. Now read these over again and again. They're simple, but these four elements have to be present for you to make any case. And in your role as advocate, you will use this. Your patient feels they have a case. They're going to take it to an attorney. Tell them, you do what you wish. But these are this is the model. Think, do you qualify for on each of these four? And no matter where you go, these are the four things that any attorney can look at. All right, legal principles. And this set of slides has a whole bunch of legal principles which are there. They're too much to have on a slide, but you must at least review them to be conversant, to go out and work and appear as a professional. Abandonment, we've mentioned that at various points. That's failure to give services to a patient without notice. All right. I come in to report to work, and they have one nurse on for 10 patients that are pretty, not critically ill, but pretty ill. They at least need medications, they need a reassessment, they need nursing care. And it is abominable, 10 patients, and I have told my supervisor before, next time I come in and find out that the staff is this short, I'm going to leave. Now, it isn't enough that you just say this verbally. You have to give notice. If you don't give notice and leave, you can be brought up on charges of abandonment legally. You can be reported to the Board of Nursing, and there's a possibility they could rip your license. It's a good way to get rid of someone, an employee. You can't stand them. Question? No. Borrowed servant. An employee under the control of someone other than the employer. I could give you examples of that. I don't think it's so important. Let's just look. Captain of the ship is an old principle. Up until the last 25, 30 years, I would say, somewhere in there. Nurses were required to do whatever the doctor told them. And the Nursing Practice Act, in fact, holds a statement that we will not in any way conflict with the medical plan of care. It's totally outdated, and in recent court cases, judges have even attacked attorneys' use of the term. In other words, today, you will be judged on what you do. If you give the wrong medication because the physician wrote it, even wrote the order, and he or she wrote the wrong medication because they sound alike, and you just wrote what they gave. I'm saying years ago, you would be clean because you did what the doctor told you. No. Now you're responsible to know the actions of those drugs, the therapeutic dosages, and when you should say, I am sorry, physician, you want to give it, you give it yourself because it's the wrong thing. I'm not giving it. Now you have to be cautious because if you do this promiscuously about everything, I don't need you working for me. You have to learn to work these situations, but there is no more captain of the ship. It's an outdated concept. Charitable immunity is a concept that is still visible in law, but it depends on the state. Charitable immunity used to be that if you were giving care free, which a lot of patients were given free care before Medicaid, you were not liable for any damages. The Massachusetts court abolished this for charitable institutions, and in other states it varies. I think in New Jersey, whoever you're taking care of, whether they're a bad debt, which is charitable care in this state, it's called bad debt, or whether they're paying, you are responsible for the care. But know that these concepts have come down over the years. Let's just jump ahead to these. You can. I want to get to the big ones. Subrogation is interesting. Subrogation, the last one on this page. That's when an employer can sue back an employee for what it cost the employer in a suit where that employee was the defendant. All right, putting it more simply. There was a big case in St. Barnabas years ago. A physician, and there was a claim paid by a nurse and a physician. The physician was operating on a woman to do a tubal ligation, which means you use nitrous oxide to inhale as anesthesia. You following me? And you need oxygen to pump into the belly, because the way they do a tubal ligation is to pump air into the belly, which lifts it, and then they go in with laparoscopic tools and do. Well, the nurse who was in charge hooked the wrong tubes up to the wrong container. And nitrous oxide was pumped into her belly, and she was given oxygen. She died on the table. There was, the hospital is responsible for the people who practice in that hospital. That's the way the law goes. In other words, if you have an incompetent worker there, you're responsible for what they do. But after they had paid all this money out, and it was millions, it was, I think, the largest case. Why was it millions? She was a stockbroker. She was a trader. It doesn't matter whether you're male or female. She had a dramatic potential in earnings for the rest of her life, and that's what you compensate for. All right? But after the hospital got sued and they paid all this, they turned around and sued back the nurse and the physician to try to recover some of that money. That's subrogation. And it's not done frequently, but it is done. Respondeat superior. This is very, very important for you to remember. It's one of the common respondeat superior means the employer is responsible for what employees do within the scope of their employment. All right? Again, the employer, the patient is assuming the employer has competent healthcare providers and competent staff in their facility, so that the employer is responsible for the employees. Respondeat superior. It's Latin, responding to the person who is in a supervisory or a superior status. Take it apart, and I'm sure as Spanish, it's a Romance language, or Latin, Italian, you can get the same gist from it someday. Res ipsa loquitur. Please, that's another critical statement. Res ipsa loquitur. Res ipsa loquitur. Loquitur speaks. Ipsa, itself. Res, evidence. The evidence speaks for itself in Latin. And you make the translation to whatever other language you know, but I'm most comfortable in that. Res ipsa loquitur. The evidence speaks for itself. In other words, the situation, the evidence is self-evident even to a layman. I told you about the hoses being hooked up to the wrong canisters. Can you see that in your head? And they turn them on, and the wrong gas is going to the wrong place. Whether it was a momentary breach or whether it went on for a half hour, I don't know. But whatever, it caused the woman to die, and she was out of control. She was unconscious. She had nothing to do with it. All right, that's the important part. It's out of your control. Stare decisis. Very important. One up from the bottom. That's when decisions are made by the courts and they evolve into new legal principles. All right? Also very important for you too. The reasonably prudent man theory is interesting. This bases a judgment on how anybody with comparable education, skills, and training put in the same situation would perform. It's not the standard, but it's another aspect of it. How would, a lot of students around OB, and a lot of them focus on technology. Different types of fetal monitors not performing. Big, lot of suits on that. The nurse comes in and maybe doesn't check the apparatus, assumes it's operating. What would the proficient OB nurse do? You're not judged according to the idiot OB nurse. Remember that. A proficient OB nurse. So you would bring a witness. If you had people on fetal monitoring, what would be the first things you would do? Well, first, I'd go to make sure all of those machines were operating. If that's what evolves as the reasonably prudent nurse action, that's what drives the case. So there is a lot of there are a lot of things here that are common sense. All right. Remember, there are a lot of problems with misinterpretation of orders, and you have to be very alert to phone orders. Physicians or APMs call in an order. They're not supposed to, but frequently it's common practice to take them. When you have someone that has a language barrier, that often becomes a mighty feat to understand what they're saying. I don't care if you have to ask him or her to repeat it 10 times. It's your license on the line. If you can't understand, you ask them to spell it. If you still can't understand, you get somebody else to help you. If you still can't really swear that he said or she said atenolol 25 milligrams, you tell them to get themselves in and write it. You can't fool around with phone orders. They're treacherous. And you have the right to question any provider when you're in doubt about an order. There are, and some of you wrote about this, there was a major study done by the Institute of Medicine a few years ago on medication errors. It's quite recent, and it was really 3 volumes. I forget the name, but if you put medication order and you go, the Institute of Medicine, all its materials are free to download. Even 200-page books, everything is free to you. And the Institute of Medicine is a quasi-governmental, it's a think tank for the U.S. government, really, the think tank. And they did a major study on medication errors. And they reported that only 5 to 7% of errors were ever reported. All right? Little things like you're late getting out your medication. If you're more than a half hour late, it's a reportable error. I don't care what you think. It's not your place to judge whether the medication did any wrong because it was given late. Half hour out of, I believe it's a half hour, you have to report it as an error. So the errors were wrong patient, wrong drug, wrong dose, wrong route, wrong time. These were the major common errors. And only 5 to 7% of the errors were ever reported. That is, there were 44 to 98,000 people that died yearly from medication errors in the U.S. And if we're that bad reporting, I'm sure other countries are worse. And medication error reporting has become a major work of the Joint Commission. The acts of negligence, I want you to look them over. They're fairly clear what they are, and you can review them. And if there's anything very important to talk about, we can pull that out next week. Record keeping is a very critical area, and nurses are reported to the Board of Nursing because of inadequate record keeping. They hadn't been for many years, but the last 10, 15 years, licenses have even been removed. Never alter a record. There's a wonderful movie, with Paul Newman. He's dead, so it's really older than he's dead. But about a nurse who altered a record in Boston, St. Elizabeth's Hospital it was. And I'll see if I can. It would be a wonderful movie for you to get on Netflix or something. I'll get the name of it for next week. But anyway, she left nursing. She altered a record and said that a patient had not eaten in the previous 12 hours when the patient did tell her she had, but the patient wanted to be induced for a birth. So she altered the record. The patient was anesthetized, and she vomited, and she aspirated her own vomitus, and she was in coma. She was not going to come out of coma either. She had brain injury. And they went to the records and found out that she had changed it. They just suspected it. And they went to search for this nurse. She was so moved by what she did and so ashamed, she left nursing. And in the final frame of the movie, she comes back to Boston and she testified about what she did. And of course, this proved the case against the physician. Very moving movie, and shows you the importance of recording. The latest 2 cases found against nurses that I could find were in regard to teaching. Nurses who did not teach and didn't record, one who did teach, one who didn't, and the one who did teach said she taught, but never included in her note any comment about whether the patient learned. Critical. If you're going to teach and the patient doesn't learn, either you hand it over to someone else, like the home health nurse, or you put down the indicators, how you know the patient learned. All right, we'll start up here again next week. Any questions at all? We have a moment for questions, always. Oh, the name of the movie, The Verdict. The Verdict. Exception. And the other one I told you about last week was Wit. Remember? That's the story of a nurse supporting the living will of a patient and not letting the resuscitation team resuscitate her. Wit, W-I-T, with Emma Thompson. Excellent. Okay. are so inspired to see something, ask me about it again. I have a batch of these at home. See you next week.